Chuck, do you want to update us on some of the data now? It's come out this year regarding OS.
Well, so the data from our most recent presentation essentially confirms that all of these studies that had MFS met their primary endpoint for MFS also meet an endpoint for overall survival. The question of whether MFS is a surrogate endpoint for an improvement in survival is sort of something that is continuing to be thought through, I think. But it's fair to say that we've now demonstrated that improving MFS in the non-metastatic setting is both an approvability endpoint and is clearly associated with a long-term outcome benefit for the patient in terms of overall survival. My sort of interpretation of this also is that MFS, apropos of what I said previously, MFS is really PFS. It's just going from radiographically invisible metastasis to radiographically visible metastasis. It's not a wholesale qualitative change in the state of the cancer. And how these data will integrate into further studies in the non-metastatic space, I'll be curious to see. Because I'm wondering if the non-metastatic CRPC space itself may sort of go away with a lot of the newer imaging modalities that we're seeing tested and presented like we did at ASCO this year. So it's going to be an interesting area. And I also think we won't be able to see any more placebo-controlled studies in this setting either.
That's interesting. And some of these studies actually allowed, pelvic lymphadenopathy. Mm-hmm. So the reality is what we actually called non-metastatic was really low volume metastatic disease. And in many respects, maybe our novel imaging is just going to reinforce it. Maybe it's not as low volume as we thought when we do this novel imaging, but it's still, at least by these standards, relatively responsive. And I think that'll be one of the questions. And Tanya, what do you think about that? How is some of the novel imaging here going to influence, your thinking? You mentioned earlier in the the castrate sensitive setting that imaging probably isn't going to necessarily change how you think about that disease biology. Will it influence it here in this now castration resistant setting if the novel imaging is showing perhaps a higher volume of disease than what our standard imaging is showing?
I'm not sure it would, given that we would already intensify either way. Once you get to castration resistance, now we have these approved drugs that have proven metastasis-free survival and overall survival benefit. And I'll add that quality of life was preserved in these trials, which is quite remarkable. For that amount of difference, metastasis-free survival 40 months versus 15, that's a huge difference. And for people to be feeling well during that is really important. So if you have a well-tolerated agent that's highly effective at castration resistance, non-metastatic, that's also available metastatic, I don't think the imaging adds too much. Just because we see more spots, do we treat it differently? I think some differences that it could impact would be whether you might add bone support if you saw something in the bone that you didn't see on traditional imaging, but that's a huge gray area, right? There's no research on that yet. Maybe we need to look to our European and Australian colleagues, as Eleni was mentioning earlier, and learn from how they're handling that type of situation.
I think it's a great point, and I think it's another setting where I think this novel imaging isn't necessarily going to drive a change in our therapy. What it might point to is another class of therapy that's evolving. We're going to get to that subject later. So it may be more useful as a biomarker for preparing for future therapy than it is for changing the current therapy in these patients. So I think that's reasonable.
Can I make a comment on that? Yeah. It's very interesting. Because we are a little bit trapped in this administrative term, non-metastatic CRPC, we have the data from the Hattershek group where if you took patients who would be accrued on this trial and you did the PSMA PET, 75% of these men would have findings, whether localized or metastatic. So let's just, for the purpose of FDA approvals and the like, we use these terms, but as physicians, we know well that it's just earlier CRPC versus later. And then, even though we can't compare trials, but we even have Chuck, who was the lead in the 302 trial. If you look at those survival benefits, even in absolute terms, in this later disease, chemo-naive versus earlier disease, you're just what Tanya brought up. The difference in what you get is quite big, as long as you're good at monitoring these patients and taking care of
Right.
that's our duty. So I think it's kind of a no-brainer, and I'm saying that because people will be then saying, oh, well, of the 3 drugs, only one has approval in the CRPC that is metastatic. Well, come on. I mean, these are agents in the same class, and then you go into the safety and the tolerability and adapting it to your patients. That's where you make the decision. You don't go by a label, just the sheer administrative label. At least that's my take, and I'd like to know your thoughts.
Yeah, no, I like that thinking, and I think back to what Chuck said earlier about disease heterogeneity and how these agents are going to work so much better in that castrate-sensitive setting when we knock down the tumor burden with ADT than waiting to the castrate-resistant setting. This is sort of like that, because here we've got a low volume, kind of chronic, development of castration-resistant. It's unlikely to be as heterogeneous as our patients that have high volume metastatic castrate resistant. And so we see this survival benefit associated with which, a 30% survival benefit in this setting when patients are going to live for 5 years or more is way more impactful than a survival benefit of 30%, say, when a patient has 1 year to live. So recognizing, that hazard ratio in the context of the overall natural history is really important, and recognizing that it makes sense that these drugs would have a more lasting and durable and greater benefit in this setting.
So I'm curious for the group. I'm curious for the group to sort of comment, because this question of using hazard ratios or using time for how we communicate with each other, how we communicate with patients. I know, as you've said, we can't compare trial to trial, but you do now have these overall survival benefits of 11 months with enzalutamide, 14 months with apalutamide, compared, and look at enzalutamide to 4 months in the metastatic castrate-resistant space. And that tells the story as dramatically as anything. I'm curious if that is something you find as a differentiator, at this point, or is it, how, in explaining it to colleagues and frankly to patients, how you're finding this data is helping you.
Can I make a quick point on that? It's a really interesting point. And one of the things I've been reflecting on and looking at the survival data and thinking about the more aggressive treatment of low volume disease is that what I think we are beginning to see is that the other causes of death are beginning to compete with prostate cancer as a cause of death in these patients. And that was unimaginable when we were treating post-docetaxel patients with enzalutamide, where everybody was dying of prostate cancer. And not only that, they were suffering a lot before they did. And now we have taken these drugs into a much earlier phase where we're beginning to see that the risk of dying of prostate cancer is going down. And it's being eclipsed almost in many cases by the risk of death from cardiovascular disease. And I think there was a presentation in Neil Shore's there was a slide in Neil Shore's presentation that showed for a man diagnosed with prostate cancer now, the risk of dying of cardiovascular disease actually exceeds the risk of dying of prostate cancer. And so that has huge implications for how we would talk to a patient in that we can actually say, not only are we going to delay the progression of your cancer, but we may, this may be your chronic therapy moving forward, and prostate cancer may not threaten your life. It's a long way before we can say that to every patient, but I sort of see that beginning to creep its way into the conversation.
It's a great point, and these studies, these non-metastatic castrate-resistant prostate cancer patient populations were generally older.
Yeah.
Than the populations of patients we're studying in these, castrate-sensitive, even metastatic castrate-resistant settings. Again, speaks to the natural history of this biology, but, probably 20, 30% of these patients were over 80, and average age is about 75. So we're dealing with a population of patients that cardiovascular risk is only increasing with time.
Ironically, this is what statins and beta blockers did to cardiovascular death, a couple of decades ago.